Ladies and gentlemen, I think you are hearing me. Welcome to today's webinar on exploring the world of pharmacy informatics between knowing the language of pharmacy and knowing the language of information technology, and working as translator between the pharmacy department and IT department. It's my honor to introduce our speaker for today's webinar, Dr. Ghalib Abbasi. He currently serves as the System Director of Pharmacy Informatics at Houston Methodist Hospital in Houston, Texas. Dr. Abbasi is educational credential or impressive as he holds a Doctor of Pharmacy and Master of Science degrees from the University of Iowa, as well as Master of Business Administration degree from West Texas A&M University. His expertise lies in the field of pharmacy informatics, where he has made significant contributions toward the advancement of this specialized area of the profession. He is recognized authority in the field with numerous publications and US patents to his credit in the areas of pharmacy informatics, operations, and finance. Dr. Abbasi is an active member of multiple national and international pharmacy organizations, and he has special interest in areas such as interoperability, sterile compounding technologies, clinical decision support, and pharmacy artificial intelligence. His dedication to improve the pharmacy profession and enhancing safe medication practices through the technology is evident in his work and achievement. In addition to his academic and professional accomplishment, Dr. Abbasi has also received several honors and awards for his outstanding contribution to the field of pharmacy. We are privileged to have him as our speaker today, and we look forward to gain insight from his vast knowledge and experience in pharmacy informatics. So now, Dr. Abbasi, the floor is all yours.
Thank you so much, Lean. Appreciate the nice introduction over there, and good evening, everyone, or good afternoon, wherever you are. I'm going to start sharing my screen, and just make sure if someone can just verify. Lean, please confirm that my screen is visible so we can proceed.
Yes, it is visible.
All right. So today, what we'd like to talk to you about is about pharmacy informatics. And we will start by defining certain provisions for this field that's interesting, and then we're going to walk through the options that you may have or see in order to proceed such an interesting field in your career. And I'm going to preface this by saying this field, not because it's mine, but I certainly believe it's the future of pharmacy. Everything is going this direction, and it's just up to the ones who want to take the challenge and just get into this journey and enjoy it, of course. So with that, I'm gonna start with some definitions over here. So many times whenever we say the word pharmacy informatics, basically you're gonna start hearing about people saying, oh, that's like lots of jargon, I don't know what you're really talking about, can you just explain to me what this means? In the basic definition, pharmacy informatics is defined as the science of applying the information technology concepts for advancing and supporting pharmaceutical clinical care. So think about applying anything you know in technology, and your goal would be to support your patient and your pharmacy delivery system across any institution or healthcare continuum that you're part of. It's an integral part also of the department of any department as a healthcare organization, and its job is to bridge the gap between the clinical and operational pharmacy teams and technical teams. So think about it this way: you have a pharmacy in a hospital, or you have a pharmacy in the community setting, or you have a pharmacy in the industry, meaning that pharmaceutical industry, and then there are lots of technologies that actually gets developed by non-pharmacy organizations or personnel, and yet you need to be able to apply these into the healthcare continuum. So the informatics pharmacist in this case, his or her job is to grab that knowledge and convert it into a healthcare technological item that actually can be executed upon to eventually help your clinical staff, your physicians, your pharmacists, your nurses, your operational staff and operations such as drug distribution, medical sheet checking, and what have you. We're going to talk about it in a second here, of course, or your patient even, because the end result is that you want to improve your healthcare delivery to your patient through this pharmacy technology that you're going to be developing or maintaining. And then what you need to do is to convert all these into what we call as sensible projects. Pharmacy informatics doesn't mean that you need to stay in theory, meaning that I can grab theory anytime I wanted, but unless you convert that into a practical experience, that theory is meaningless, literally. So you have to be able to convert it into a sensible project that actually has an effect and some benefits that you can measure on your patients. And your goal, again, is to maximize the pharmaceutical care provided to everyone involved. And then last thing is that the definition also includes that this pharmacy informatics utilizes available healthcare technologies, and what it does, it integrates them into the healthcare continuum. That's very important because you're not living in a silo over here. Anytime you're working with pharmacy informatics, you cannot just work in a silo. You have to be able to integrate with everyone else who is working in the healthcare industry and who is actually delivering that care in your institution as well. So if we're going to be looking at the pharmaceutical technologies over here, so the easiest way to think about where or how the pharmacy informatics fits is to divide the medication life cycle into 4 stages. And those are the stages I'd like to always divide any conversation about. We have the pharmacy informatics residency that we're going to talk about in a couple of slides here. But the idea is that each one of these life cycles take literally a full rotation. And we're talking about like 4 to 8 weeks of rotation per item. So here we're just summarizing something that actually takes a long time to learn. But that's for you to know also how the life cycle is divided anyways. So the first item is prescribing. And that's how your medication life cycle starts. You start with a prescription. You have an evaluation happening to the patient. You have diagnosis going on, right? You have a provider standing by a patient bedside or someone who is in the physician office in the community. And then that prescribing, it used to be, as far as you know, back in the day on a piece of paper, you give that to a patient, they go to a pharmacy and what have you, and still practiced to the day, actually. However, in a healthcare institution working with advanced technologies and with more error reduction technologies, such as an electronic health record, that writing of a prescription is becoming very much outdated. And I understand in Jordan, they use a system called Hakim, I believe. So that's a good example for what's called like as a homegrown health electronic record or system. But if you look at the globe, if you look at like the world and how things are happening across the universe here, basically you'd have certain key players in this area. If you hear the names of these companies, Epic or Cerner, those are probably the largest organizations that actually govern the electronic health record provisions in the world. Certainly in the United States, but more certain and more growing also in Western Europe and in the Middle East as well. And then you have something else called the pharmacy information system. So what this is it's a smaller system than an electronic health record. So think about the electronic health record as your entire computer system that governs everything related to the patient, from lab to imaging, to emergency visits, to billing, to scheduling, to all these kind of things. And then the pharmacy module is just one of them. But sometimes what we used to see in the past is there aren't actually too many of these are built in because they're just so expensive. I mean, I'll give an example here. In order to build a system like Epic, and let's give an example of a five hospital system in the United States, let's say about maybe 100 medical centers, just as an example, you're talking about like about $300 million over here, just for the organization to invest into something like this. So it's not a cheap investment. So many cases, what they used to do with these hospitals, they used to go back and invent what's called a homegrown system. Sometimes the homegrown system is only just for the physicians, meaning that you go and you document your notes on that chart. Sometimes it's only for pharmacy, where you just only go and document your medications, and you need to integrate these two together. So the informatics pharmacist would actually be able, or should be able, to troubleshoot the pharmacy information system primarily, but also integrating that system with everything else, including if you have a homegrown system, such as, and we don't have the names over here, but there are lots of them. One of them I used to work on in the past years called Care Plus, very homegrown system. Now, I think it's now like even not used anymore. But the example that you have in Jordan, Hakeem, is a good example of that electronic health record that is also considered like homegrown with maybe certain provisions here or there. There might be some pharmacy component in it, but might not be that comprehensive. And sometimes you'd see some sort of additions to these homegrown EHRs in the form of, let's say, something that tracks dispensing from pharmacy, or something that tracks maybe dispensing from pharmacy, what have you. However, we're still at the prescribing phase over here. And that is basically like not where the pharmacy is focused on, unless, of course, you are a practicing or provider on the floor, participating in the clinical rounds and actually writing prescriptions over there. This will impact you big time. And that's where that clinical decision support is related, because this is one of the major items that an informatics pharmacist work on, which is what we call the clinical decision support. And a good example of this is, let's say you have a patient who is allergic to penicillin. Okay, that's just a basic example of a clinical decision support. And then you have a provider who is actually trying to put down an order for that patient for amoxicillin, right? Well, the basic expectation is that the system is going to flag the provider, say, hey, I'm sorry, but this patient is allergic to penicillin. You should not proceed with this order. But then clinical decision support goes beyond that, because it relates to the drug-drug interactions. It relates to the rules that you actually set per medication, per dose, per weight, per gender, per perhaps certain physiological outcome, before you actually kind of like provide that feedback to the provider at that point. Then the next stage would be your preparation of the medication. And this is where it's straightforward pharmacy related. So here, you have a couple of examples. You have the IV workflow systems, and those are the systems that are used to semi-automate and sometimes fully automate the sterile compounding process. This is important because the sterile compounds are probably the weakest links in any hospital department. The idea is that you're talking about sterile compounds, and if there's any contamination going on with these, you're talking about like costing someone's life in this case. So there have to be no or very, very, very limited errors associated with this. And these systems help a lot. The informatics pharmacist is the one who builds those databases for medications, builds those limits, builds, for example, the beyond use dating requirements. Sometimes you build the algorithm, actually, the algorithm that actually decides what goes before what. Meaning that if I'm compounding, and if depends on what you're going to be using, USP or BP, depends on like which country you're practicing with. But let's say you'd like to provide an expiration date for a compound. Let's say you compounded cefazolin 1 gram and say 250 milliliters of normal saline or D5W, whichever one you want. Then the idea is, okay, so how do I determine the beyond use dating over here? Who determines this? Per USP, it depends on how many ingredients you add actually to the compound to say this will be good for 48 hours or 24 hours, right? So instead of you sitting down and guessing all this stuff, this system is going to just basically like print it out for you on the label based on the algorithm you're going to be feeding in this. And only the informatics pharmacists are the ones who are going to be able to know how to actually configure this out correctly and have that label printed with the correct beyond use date expected. And that's the mainly difference between informatics pharmacists and someone who's just come from the IT department, because that person has no idea what the clinical practice is. So they have no idea what they're verifying. So here's what the field is going to be important for sure. The other item is the TPN compounders, and those are straightforward devices that would actually compound your total parenteral nutrition. You hang those ingredients in there. And I think there are a couple of these in the Middle East, I believe, because there are several vendors who actually sell these products across the region over there. But again, the database over here and the calcium phosphate curve is something that is actually designed and implemented by the pharmacy staff, pharmacy informatics in this case. Because at some point you want to make sure that you're not adding too much calcium or too much phosphate, because you're going to cause precipitation. How can you automate this stuff? Is through knowing how to set up those limits in there. What's better than that is how you actually integrate this TPN compounder with the IV workflow system with the electronic health record. So when you put an order at the prescribing level, it flies all the way throughout all these systems flawlessly and actually execute nicely at the end of the day for a dose that actually have no one actually manually trying to manipulate or enter. The last thing you want to do is have someone just manually enter something in the system. That is the least preferred or least desirable outcome over there. And that's the goal that you should be trying to achieve being an informatics pharmacist over here, is to eliminate those manual steps altogether as much as you can. And then you have those unit dose packagers. Typically, those are very large devices. Sometimes they're like in the millions of dollars of cost. And their job is actually to basically receive those orders that you're sending and then prepare those doses for dispensing. And then they're going to be actually being dispensed for the patients. Labeled, packaged, barcoded, all good to go. Sometimes you also add what's called RFID, which is the radio frequency identification devices, the small chips that you actually would assign for certain medications before you dispense them, either because they are critical or because they are expensive or because they're just on drug shortage. So you want to make sure you track them across the institution. What this means that at any given point in time, I can know where everything is. I don't need someone to give me a call to let me know where a medication is. I can actually track it like a GPS, basically, and know exactly where that dose is and go and find it if need be. And then you'll go to the distribution phase, and that's where you are actually going to now send those medications, you dispense them, and you put them in the hands of the providers. So here you're talking about the automated dispensing cabinets, and I'm not certain if they use these in Jordan, by the way. I'm not certain because this stuff is very expensive. I mean, these ones here, and the two main players, by the way, in the market here are a company called BD and another one called Omnicell. Those are like the biggest players here, but sometimes you have even like smaller companies play with this. But something like this, you're talking about like maybe $30,000 to $40,000 per machine. And then in an institution like for us, for example, here at Houston Methodist, we have maybe like 700 of these across the organization, because we have like about 8 hospitals, and there's a 9th one we're going to be opening next year, and about like 200 PO clinics or physician organization clinics. So a very large health system over here. You probably won't see that footprint anywhere like closer in the region over there, but at least gives you an idea of how expensive these are. But again, the informatics pharmacist would come here, and those configurations for the medication, for the minimum and maximum, because remember, part of your job would be the clinical practice, but the other job is the operational piece, meaning that you need to know how much you manage your inventory. Is your inventory here optimal? Are you expiring too many medications because you're not using them very often? Who's going to be setting that par level, and who's going to be monitoring it? That's you again. You will be setting those par levels, minimum and maximum, and even like program how often these will be ordered. And if something is not even moved that often, you probably need to even reduce that par level, or even take it completely out of the machine altogether. And there's a whole science behind this, by the way, over here. So we can discuss in more details, perhaps in future settings, but those cabinets and those systems altogether, they're all interconnected. Whenever you enter an order here, it propagates through the whole system over here. You will hear something in pharmacy informatics called the source of truth. Source of truth means, where is the data I'm going to be trusting here? Where is it coming from? And usually the source of truth is here in the electronic health record. You don't want to have too many sources of truth, because you want to make sure that if you have a drug built somewhere, let's say I have an atenolol 50 milligrams tablet built here, then I want to make sure that this configuration is actually built correctly in your dose packagers and in your automated dispensing cabinets, so you can actually track things correctly over here, and any user will just read the same information all across. For sterile compounds, same idea. For certain preparations, you may even need certain chemotherapy compounding devices, by the way, which is similar to the IV workflow systems, but has different configuration, of course, because of the sterility requirements and the hazardous drug nature that you're going to be dealing with. Back to the distribution, you also have the pharmacy automated storage cabinets or carousel, and it's basically like a cabinet that's actually built into the wall. And there are like several versions of these, but this is just one example over here. So basically what this is, instead of like putting your medications on shelving, you would store them actually in a shelf built into a wall. And it's like it rotates, like we call it like a carousel, right? So it rotates. And the way how this works is that if you have an order for a patient, whether it's a patient-specific order or whether you're trying to use this to replenish your automated dispensing cabinets with medications. So medications from here can either go directly to the patients or they come here to replenish this. I'm not sure if you know how these are used, but these are used by nurses for the most part, because you put medications here in these drawers and QBs and what have you, and then a nurse would come here to the screen, look at his or her patient, right? And then if that dose or order has been verified by the pharmacist in pharmacy, then it will be allowed to be dispensed. So the nurse would come here and click the button for that patient, open the patient chart in the dispensing cabinet, find that medication that has been verified. Let's say that was a morphine 1 milligram syringe. And once he or she clicks on that, then a drawer opens up and the QB pops open, and they only remove the dose that they're supposed to take. If it's not verified by the pharmacist, it will not be allowed to be taken out. That's another safety feature that you control, because then someone's going to come and ask you, okay, how are you going to design a hospital in this case? Are you going to design a hospital by saying, I'm going to be putting everything in the hospital as pharmacy verified? Maybe not, because the problem here is that not everything actually can be verified in time over here. An example would be in the OR, in the operation room. No one has time to verify an order for fentanyl for a patient on in the OR on the bed, just waiting for treatment that needs to be given within seconds. So in these cases, what you do, you would designate these machines as what we call them non-profiled, meaning that you can take whatever you want from there, however it's can be documented. And someone needs to go back then and just reconcile that. Usually that's an operational demand from nurses. They usually go and just reconcile whatever they removed from these machines with whatever has been ordered during the operation theater procedure in the electronic health record. And that's how we sometimes discover discrepancies. Now you're talking about drug diversion, abuse of medications, and what have you. And that's a major topic, by the way, if you start talking like abuse of controlled substances. And they're going to always come to you and ask you these questions as an informatics pharmacist. How can I find those people who are abusing controlled substances? Well, you would either know how to run the database over there, or you would have a software, which is more than likely what's going to happen, to help you with these diversion monitoring protocols and to find out even probably who is actually diverting your controlled substances. And there's a whole science behind this, by the way, because sometimes when you use a software to do this, they usually look at, for example, certain users who basically vended certain medications more than the average of the rest of the users. So for example, you see like a nurse who maybe took let's say 15 syringes of morphine in a given shift and given number of patients compared to the average of, let's say, 10 compared to 2, which is the rest of the institution. So at that point, it's not like you just go and just, let's say, come to a gotcha moment and just grab the patient, just start the, disciplinary action, of course, but it gives you an idea to start the investigation process, of course, over there. Again, who monitors all this stuff? Pharmacy informatics usually provides the solution, provides the statistical power behind this. Because usually most of these diversion protocols, they look at something to maybe to the extent of 3 standard deviations. So if I'm a user with that 10 syringes, right, and then you have the median use, which is, let's say, 2 syringes, then you measure 3 standard deviations out of the 2 based on that like range, and then anything outside the 3 standard deviations is considered like a probable diversion for investigation. That's how the 10 falls usually outside like that range of the average of 2 for the most part. But that's a good example just for you to think about where this can go. But then back to this automated carousel over here. So again, this can go to replenish those cabinets. This can go to perhaps be a patient-specific dose. And the only way to take something out from here is that you scan a barcode. So for example, you would have either like a label, that's one option. And if you scan that label actually in that carousel or dispenser or storage, then it will start rotating until it gets you to where that is stored. And there's like a laser beam that actually looks at where that is stored until you grab it from here. When you grab that dose from there, you need to scan it again, because then the system needs to make sure that you actually capture the correct medication before you send it out to the patient. Another way to do this is that you receive all these orders right on the screen here on that carousel. So what you do is that you have a list of orders that need to be processed, whether it's like patient-specific or replenishment, and just like select which ones you want to execute. The moment when you select something, a label will print out for you. So you can put it on the baggie or whatever you're going to be sending to the patient. Again, carousel rotates, you grab the dose, you scan, put it in the bag, and send it to the patient. And then we're going to go to the administration part, which is where you're actually going to administer those medications. Now, those medications you sent from here, they will be scanned in this electronic health record for nurses in the medication administration record, which means that you are not going to be actually given a medication for the wrong patient because you have to satisfy those 5 rights for nursing, right? So, but one of them would be the right patient, right time, and the right medication, right? So what you do in this case, you would scan the patient armband, right? And then what you'll do is that you will scan the medication. And then if there's no medication order for this patient, the system will not even let you proceed because you're supposed to give this to someone else maybe. So that's how we capture these. So you can see there are like several layers of protection before that dose gets to the patient. And only the informatics pharmacist, the one who actually looks at all these all together and actually monitors them and make sure like that Swiss cheese model, if you heard about this term before, Swiss cheese model, you know how the Swiss cheese is like holes in it. So usually that term is used in the Western world for the perfect storm, meaning that I put all these layers of protection, but then there's only this one incident that will happen that will actually penetrate to all the holes in that Swiss cheese model and cause a problem. Your job is to actually make different mechanisms of protection so these holes do not exist. And that's how we can prevent medication errors at the end of the day. Here, the pharmacist would actually control the smart infusion pumps libraries. So anytime you infuse a sterile product here, what the informatics pharmacist is going to do is going to come here and they'll program those smart infusion pump libraries, which actually propagates to the entire fleet that you have that nurses actually use in this case. And we'll tell you, okay, you know what, let's use the example of cefazolin 1 gram and 250 mils of normal saline. Then we know that we need to infuse this over 30 minutes. But you don't want to infuse it over 1 minute, do you? I don't think that's a good idea anyways, because the maximum I've seen with cefazolin push is maybe like over 10 minutes if you're going to push it, right? You shouldn't even go faster than this because you're going to cause like an extravasation. But let's say that someone made a mistake at the pump and they wanted to actually, they made like an error with a decimal point. Instead of saying like infuse over 30 minutes, they missed putting the 0 and they just put like 3 minutes. Your patient is going to immediately get extravasation and very local reaction over there in the skin at the place of infusion. Very undesirable outcome. Your job would be to have this library set up to have what's called like a soft or hard minimum, depends on what you're talking about, and a soft or hard maximum, which means that if someone tries to infuse that cefazolin at 3 mils over 3 minutes, all right, that bag over 3 minutes, the system will stop them because that rate of infusion is not even allowed on these. You as a pharmacist would actually control that and you would actually push this library to prevent a disaster from happening in this fashion. And then the last thing here I want to talk about is the clinical surveillance, which is basically the clinical system that's used to look at your biograms, how are your patients basically prioritized in terms of like outcomes over there, and who needs to be monitored first. Sometimes this clinical surveillance system is a standalone system. There are several players in the market for this. The most famous ones are, I think they're called, one of them is called Vigilance, the other one's called Theradoc, the ones that play with the clinical surveillance system. But then this also can be built in the electronic health record as well. So keep that in mind as you see these, that informatics pharmacy is involved in almost like all of these altogether. And then we're going to be talking about here, let's move on to some advanced pharmaceutical. So all this stuff we talked about here, folks, is the basics. Okay, this is like basics for informatics, so what I call like informatics 101. But now what we do also, we have also, 102, if you will, of advanced informatics roles in this case. And in this case, I'm going to just put some items for just to tease your mind about it, for you to think about for the future. The first thing is interoperability. when you hear about interoperability, this is the science of either integrating your systems together so they speak the same language, meaning that you link them in order for them to exchange data in a meaningful way, or you link institutions within a city or a country or the universe to actually receive data and analyze it. This is actually very important because on the smaller level, this infusion pump we talked about, this library, there's a way you can integrate this with the electronic health record, meaning that whenever you have orders entered in your electronic health record, they go actually wirelessly to the pumps over here. And you, in this case, avoid the programming of the pumps manually. Actually, the order just gets there. And the only thing the nurse will need to do is just to verify it. Just make sure like it's there. Of course, in this case, the scanning is important because what you do in this case, the workflow is that you scan your patient wristband, you scan the medication to be infused, and then you scan this pump. There's a barcode that we put on these pumps and we scan them. And then the electronic health record is going to tell you, check the pump and verify that I sent the pump the right information. So the same info you have on the order will just go on the pump. You will not touch anything, but just make sure they're correct. And you make sure you infuse it then. The other part, which is that interoperability with the universe, which means that if you have several healthcare institutions submitting data to a hub that actually looks at these and aggregates them all together and gives you back meaningful information or data. This is very important research, by the way, and very important in rare disease identification, because if you have like one case in a million cases, then what's easier to go and read literature about this stuff on the rare occasions it happens, maybe like it's an N of 1 research paper or something, or maybe look at maybe several hundreds of millions of patients' data and learn from it. I think the latter is the most appropriate here because that gives you actually more matching points and more real world data. Remember, informatics is all about, you know, the sense of reality whenever you're discussing healthcare outcomes. The other piece is voice activated technologies. I'm sure some of you do have this in your home. It's called Echo Dots. Sometimes it comes as a screen called Echo Show, which has like a monitor in it. But almost, I would say, like most of the household do have this stuff these days, and they're now very dirt cheap that actually people like can buy them and just have fun with them. You'll find people like, you know, listen to music on them, play games, all the kind of things. But in healthcare, we also use them. So here, what we've done, at least in my shop, I started work on this a couple of years ago, where I had a team that was designated to apply an algorithm basically for providing patients drug information, side effect data, and routing that to your electronic health record as an M-basket, the term that's used in Epic mainly, for your pharmacist to follow up on them. That's a communication methodology that you can use very easily to track certain provisions in healthcare, to communicate with your patients and also get their feedback. And remember, in informatics, why is it like so growing so well these days? Because it actually works very well with how your life is going right now. Today, you go home, you have a cell phone with you, smartphone, you sit down, check your email, do shopping, do banking, check news, everything is on a smartphone right now. Also, many people do like these devices also as well, because, you know, I just like order it by voice and it just runs the lights for me. Sometimes it runs your security system, what have you. So you have to go with the flow basically here, and you have to provide technologies for patients and clinicians that actually work out for them. One use case that actually I'm trying to build here, and we're just working with Microsoft and Amazon on it, because you need to engage people from California to work on this, is to see if we can actually use these devices to alert pharmacists and the central pharmacy for anytime if you have like any anti-bleeding agents like protamine, or let's like any bleeding reversal agents, because these will need to be dispensed very quickly. So the way how we're trying to do this is, if there's an electronic health record order for these, that order actually comes here to this device, and this device starts announcing that in the pharmacy actually, until someone actually goes and actually works on that order. But there's also some algorithm behind it, because you need to have pharmacists who are also controlling which medications actually are allowed here and which ones are not. So that's one thing that actually we're working on right now. I think we're seeing positive results so far, but I still would like to see more testing before I can declare victory over here for sure. The other thing also that you use this for is communication in your sterile department, IV room, and outside the IV room. Why do you want your pharmacist or technician touching those intercom devices or lifting a phone, making a phone call, contaminating your hands and your fingertips on a dose that will go to the patient eventually? Why don't you just use your voice and just like open this? You can say, Alexa, call Central Pharmacy. You open the line. Hey, by the way, can you send me more vials of meropenem? I'm out. That's just way much easier to do it by voice versus having to jeopardize someone's safety by touching their vials or sterile products. Then you also have the workflow guidance. So this is also something that I personally start working on a couple of years ago here. Those smart glasses, basically we integrate them with the workflow. You can use them for second opinion during surgery. Because see this smart glass, it has here a projector that goes over the right eye. It has a laser beam here that can actually scan barcodes for you. It has a camera and it has speakers and microphones. And you can tether it to an iPhone or an Android. And basically what this does is that you can use it for a second opinion. You can use it for process improvement if you're doing unit inspections, because then you can use your voice to document actually on a file your findings. You take pictures if you'd like to by voice, and then you just find the file waiting for you at your desk when you're done. That's one use case. Another use case is your inventory, because it has a barcode scanner over here. So we're trying to see how this can work actually in a couple of use cases here. One of the residents actually was going to be joining us in the program, in my program here. I'm going to assign this for them as a project actually to continue on it because I want them to also elaborate more on these and just expand their horizon to what they're learning. And this is one toy I usually like to toss for people when they come here to play with. But that's one example. And then of course you have the mobile technologies. So those mobile technologies, basically, like we said just a minute ago, anything you're doing on the desktop or laptop, you better do it also on a mobile device. Why do I need to have a nurse document the administration using a laptop, bulky laptop or wheels on, workstation on wheels or computer on wheels or whatever you call it, versus if you have a mobile device like this where you can actually scan through it. You can scan like your administrations, you can document your clinical flows, put in your plug and just go. Just be more mobile. That's just one thing also the pharmacist would be able to configure and work on and just make sure it has a maximum clinical use. Telepharmacy is another one as well, because then this is how you do your counseling. So for example, let's say, you have a patient who's coming to Irbid, or Ramtha. Let's say they're coming from Ruwaishid, okay? They're coming one day to get that therapy and they go back, and then how are you going to reach out to them? So basically you need to have a way that you can provide that telepresence actually between you and them. And not only that, because telepresence has been there for maybe the past 20, 30 years. We're not talking about a FaceTime here. You're talking about a full service that you're referring to. So an example would be, if you have a patient that needs to be treated at home, then you will need to be able to actually provide instructions programmed and perhaps have a camera maybe stationed in a given room in their house. And then you probably have those medications available there, maybe locked somehow. And then this telepharmacy would be able to counsel the patients and actually remotely dispense those medications in the house using that cabinet over there. We're still working through some of these because there's some security issues that I'm concerned about, but that's just one use case to think about, when you think about telepharmacy and where else this can go and how far you can reach actually even within the country or outside the country for one item. Last but not least is the artificial intelligence. So basically for this one, and that's a topic on its own, basically you're using what we call predictive analytics to predict an outcome. So the difference between artificial intelligence and running a report is that you're having all these data points that you gathered throughout your system or the country or wherever you want it, right? And then what you do in this case, you capture all this data and you basically match it with your own patients, because I need to know if the patient I'm treating has happened in the past sometime, because it did, stories just happen in time like anything else. So someone else saw your patient or a similar patient sometime in life. The question is, why don't I use that experience to predict the outcome for my patient here? That is what the artificial intelligence does in healthcare. It's helping the clinicians predicting an outcome based on experience that I'm teaching this machine over here. You start with something called machine learning for the basic tasks, and then you go to artificial intelligence, which applies the predictive analytics to tell you exactly what's going to happen if you do a certain provision over here. If you, like, for example, order a certain medication, what happened, right? So that's that. And we can, each one of these topics, quite frankly, we can talk about that for hours, but it just kind of like gives you an idea of like what the informatics covers in general on the advanced side over here. Now, in terms of training for the informatics, the best thing is to get a pharmacy informatics residency program. Those ones are currently limited to the United States. So basically, you can do either like what's called a PGY 2. So basically, what you do, of course, you do a PGY 1, postgraduate year 1. And there are certain hospitals in the Middle East who do these, even in Jordan, I think. Hussein Center for cancer does some of the stuff with certain limitations, of course. And then you have many hospitals in the region that does a PGY 1. There is no such a thing as a PGY 2 informatics in the Middle East, although I'd like to see one if I can, actually. That would be great, because it's a much needed science in the Middle East for sure. Or there's a combined program like the one that I have here. So I started this program here at Houston Methodist 4 years ago. And at the time, there was only just 5 programs in the entire country of the United States for the combined programs. If you look at only the PGY 2 programs for informatics, there are like about 20 over here. You can search for them in the ASSP directory. But right now, I think there are about maybe 7. This picture is a little bit like outdated, but right now we have like 7 combined PGY and PGY 2, which means that when you're done with the PharmD, you jump on and you join the program and you stay with me for 2 years. And then I'm going to graduate you as a very experienced, high caliber informatics pharmacist who the employers will compete for. I was sharing earlier on with the leaders for JOST that I had the first graduate who we graduated from this program a year ago. She started receiving job offers maybe 7 months beforehand. And I ended up even giving her my own offer because I wanted to work for me at the end of the day. So I ended up hiring her. But just to give you an idea of like how competitive this field is, this is the best way to do if you wanted to really specialize in informatics. That's not the only way, of course, but that's the best way over here. In the program, the residents will spend, rotations. Some of them are short, like 4 weeks or a month. Some of them are 2 months old. 2 months long. And you start usually with core and then specialized areas. So I start by teaching you by preceptors, of course, certain core levels of or core provisions of clinical pharmacy, drug information, critical care, ID, all the basic stuff that we teach. And then year 2, we give you basically the informatics focused year. And then you do projects, of course, and you travel and you present in conferences and what have you. And then I certify you, of course, with the electronic health record. I'm probably the only one in this country, as well as Johns Hopkins. If you hear this name, that's one of the most elite organizations as well. Just us, Houston Methodist and Johns Hopkins, are the ones who actually certify people with EPIC or electronic health record certification for the pharmacy module. What this means is that you finish from either my program or from Johns Hopkins program. And basically what you do is you just basically like slam dunk a job that's very high paying job actually in this country. So that was the goal. And then of course, graduating high caliber graduates as well. This is a formal graduation for sure, because you go through Pharm Academic, which is the admitting program and the evaluation program. You would meet with us at mid-year in December if you apply and you'd like to come, and then we'll go from there. And you get a formal graduation and certification. The other thing I want to talk about before I open it up for questions, some key questions, kind of like this, just spill them out here for you all together, because then we can like talk through them all together. Some of them do intermingle. So these ones, let me see. Yep, no, these ones here. Let's see. Sorry. Yep. So day of life for the informatics pharmacist. Let's skip that for now because I'm going to show like quickly a slide or a couple of slides after this to show you what an informatics pharmacist does. Actually, it's a presentation. The one I'm going to show in a second, it's one that's prepared by one of my residents over here, because typically the residents here show the future residents what to expect. So I'm going to show what each of them show each other, like when they show up, and I have to sign off on this because I'm supposed to be in charge over here, but yeah, I'm the one who they send this over to me to sign off on it. And then how do you compare the traditional retail or community pharmacy jobs with the informatics pharmacy job? Day and night difference, because the idea is that if you work in a community, you barely deal with any sophisticated systems that you see in a hospital setting. The hospital has way much more technologies and components due to the criticality of the patients you see over there. Now, informatics exists wherever you want to go. It exists also in community and retail, but not to the same level of the hospital setting for sure. And then if you compare the jobs themselves, I think the informatics pharmacist job is a way much more high rewarding job for sure, because you actually utilize what you learned in school big time on the job versus using only maybe one or two aspects of what you learned, such as like dispensing and counseling with patients, which are important, by the way. I mean, community or retail jobs are also important. Nothing is not important here. But I think the informatics job would be more satisfying for most people for sure over here, based on the provision and the complexity that it offers and the satisfaction you get out of it. And then someone may ask, what kind of experience or certification required to land the job? You know, the best thing you can do is do the residency and the certification of the electronic health record. Those ones are slam dunk ones for me. I don't think you need to have a master's in healthcare informatics necessarily. It's a plus for sure, but it's not a job requirement. Always look for the job description that you're applying for. That will be your best guide to know what's required and what's not. And then a question of if there's any hope for any entry-level pharmacist in the informatics field, certainly. Basically, what you need to do, you need to get engaged in projects. So either you actually do them on your own. Maybe you can invent an app that does something for pharmacy, or you volunteer in a hospital, or even like do an internship in a hospital. Either way, but just make sure to be engaged in projects that are related to this. That what will give you an edge over anyone else who did not do anything different. A good advice for students or pharmacists that are seeking job in this area: get engaged with projects. That's the best thing you can do. Don't lose hope if you're already an established pharmacist, and I know this may not apply to the audience over here because most of you are students, but sometimes you have this question for pharmacists who has been in practice maybe for 10, 15 years. They come and ask you, I want to get just out of here. I don't want to like keep doing this job. I want to like learn something new. And for those, I say, yes, engage in projects, just, know more about the field. So at least when the time comes, you're ready. And there's nothing impossible here. You can do it. For students, best thing you do, first of all, think about whether this is the right field for you or no, and then seek hospital employment, residency, or project work. All these are ways that will lead you to this field for sure. And then several ways to get the electronic health record, whether it's EPIC or Cerner certified. So basically, those organizations are just so huge that you need to be working for a hospital that actually use these systems, because the idea, these companies, they don't like someone from the outside to come and like just apply for them, because they're concerned about consultants and competition and what have you, just someone just come and learn the system and go and start teaching about it. So what they do, they tell you, what, hey, if you are a hospital who's using the system, we will train you for sure. And of course, it can be costly. That's why I decided here to pay for my residents, because a resident by definition is an employed pharmacist within the organization. I can easily train them for sure. It costs some money. It's not for free for sure, but I still would like to pay that and train them, because I want them to make sure that they're very qualified and successful in their career when they finish. Any specific programs? The ones that we showed on the screen before are the ones that are there. You can go to the ASHP directory and look there, and actually you'll find even like more options as well for informatics. Here's just I'm not going to go over this, of course, in detail, but here's the program I have in here. So you can see this is like the PGY1, PGY2 combined. Basically, what we do in this case, we teach you core rotations. So in the residency, you would learn about internal medicine, med safety, drug info, oncology, pharmacy administration. I think I changed this like all the time, so it's not exactly what we do today, but anyways, still serves the purpose. And our website has more info, of course, if you guys wanted to check it out. And then, of course, you would have more specialized rotation, which will deal with dispensing and with clinical decision support and what have you. It's just like an example of what you see in both year one and year two. And then, of course, the EPIC certification is there. And that's that. Let me show you one last presentation before I turn it up for questions, because I want to make sure that you also see how a resident life looks in general. So let me just share this with you. And let me sure I share with you the right screen. I think it's this one here. And all of you should see now a screen that says Houston Methodist Pharmacy Informatics Residency. So again, this is prepared by, and if you don't see it, please let me know. This is prepared by one of the residents that we have here. Again, with this, how they teach people like about the show and the showcase like the residency for the future residents. So basically, that's how your day in life is. So PGY1 is a clinical year. PGY2 is informatics based. And then basically the informatics team works on the ticketing system. You have either like service requests, incident requests, may not make sense exactly there to you, but basically you have certain classifications of these, of anything that needs to be adjusted in the system, whether it's like a project or a break fix, right? And then we engage them with projects. So basically those are like just sample projects from last year. There was like a project for RFID and Bluetooth low energy tracking of crash cars. Those are the cars that you actually send over to the hospital, and you want to make sure you know where they are, because sometimes if something's expired, well, you need to change it right away, right? So that's what tracks you and leads you there. Actually, the resident that I have now in this program, she applied for a grant from ASHP and she received it. I think it was a grant for something like $30,000 or something, but she received a grant from this one over here. And I was in this submission also as a senior investigator too. So this was good. I mean, I think that's something that you can think about if you decide to go into this field, that you can actually become a researcher as well and apply for grants like anyone else. Just a couple of examples of projects they're doing here. And then, of course, what they do is they work on the EPIC, which is the electronic health record. Willow is the pharmacy module within EPIC. And basically anything pharmacy related is actually configured by the resident in this case. We train them to do this. That's how the whole point of the residency program is, to make your hands wet. So when you're done with me, you actually know exactly to go into the market and just start working there, versus teaching you theory, because I don't teach people here theory. If I don't teach you how to be a practical person, then I failed as an instructor and as an educator for you. And that's why I have about maybe like 8 different preceptors assigned to these. And the goal is to make sure that, yes, we show you how things are done, but most of your part, you'll be doing this stuff yourself, because I want you to know how to do it yourself. If you don't do it with your hand, you'll not learn it. That's just a couple of things that the people are working on. So you can see configure medications, dispensing logic, clinical decision support, you design reports, of course, you provide access, you monitor access, and there's a big piece about billing that actually is very, very important here. That's just a screenshot from how EPIC looks like. Basically, that's how you build a medication, and then you measure like for, you show the creatinine and potassium levels in there. And then those are the options that you configure. So for example, an informatics pharmacist is the one, see, this is the provider facing screen. So a provider will just come and see this and say, okay, I'm low DPM, right. It's defaulted to 5 milligrams. I can do 2.5 or 5 or 10. The question is, who determines 2.5, 5 or 10? It's you, the clinical pharmacist. You are the one who's building this behind the scenes. You are the ones who's given this physician these options. These aren't just coming like this. You are the one who's actually deciding whether the only route that this allows towards oral, you cannot do this IV, for example, right? You are the one who's actually limiting this option over here for those. And you can build on this. We talk about this automation, but that's what the informatics pharmacist does. They also look at everything else we talked about earlier, and you integrate them as well with the electronic health record. Basically, your typical day would be variable times, activities, depending on what you're doing with the rotations. And you have interdisciplinary rounds. Basically, that's year one, basically. So if you're having any services that you need to be assigned for, such as like, advanced heart failure or pulmonary arterial hypertension, or any teaching service. By the way, this program that I have for you will give you a teaching certificate from the University of Houston, by the way, just FYI. And then you do consults, if time permits, you do more projects like those smart glasses and what have you. And this is basically how your time will be divided. So basically, typically as an informatics pharmacist trainee or resident in PGY2, you would spend about these maybe 3 hours in meetings, which are not just chit chat. Basically, you're spending some time working things up, group decisions, asking questions, answering questions, and then team updates. And then ticket work is about like 3 hours over here. Because see, if you don't know how to configure something out here, you would meet with someone to know how to configure. So all these are like actually working hours over here. And then of course you have the projects that you're working on. So these ones are maintenance items. These ones are projects. Okay. And then of course you check your email with 1 hour. And sometimes you spend more or less, depend on how your day is looking. Okay. So that's just my presentation, and I'll be very happy to entertain any questions at this point.
Thank you, Dr. Abbasi. It was very valuable presentation. Actually, I will see the chat box and Q&A box to see if there is any question. First, a question from Muhammad Sartawi. What about data integrity and audit trials for the informatics system?
Okay, yeah, that's a good point actually, because the data integrity, or what you call data governance, that's what you refer to it, the governance. Basically, that's where I was mentioning the source of truth here, because the data integrity is very limited or linked to the source of truth, or the truth system that you have in there. If you have several data points that you're entering, then at some point you need to do some reconciliation, which is a problem we've seen in the past, by the way, because not everything came at the same time. For example, when we implemented the electronic health record many years ago, instead of an older system, there used to be lots of ancillary systems available as well. Now, these ones came, those ancillary systems came, and then the electronic health record came in, and there was lots of data points that actually you needed to match in this case. So there was lots of work that needs to be done over there. The best thing to do, of course, in this case for data integrity, is to create what's called a governance committee that actually looks at these discrepancies and looks at the reports that are running out of this. Because the moment when you discover there's like nonsense going on, you need to revert back everything else to that source of truth. That is how you manage that integrity and how you audit them. The best thing also is to run the real practice versus your current reports and see how it works. An example would be readmissions in the hospital setting. So if you, for example, know that your data is telling you that readmission is expected based on your outcome to be at maybe 70%, but your actual readmission is like 90%, well, that's a problem, because then you have that gap that you are not covering with your reports on a certain patient population, right? That's how we do these. So basically, it's a multidisciplinary approach to govern the to establish that data governance and make sure that data integrity is captured.
Thank you. From Muhammad also, what about system backup for the data?
That's a good question too, because in any good organization, you should have like a redundancy somewhere. So basically, and I'll give an example of what we do here, because I think that may make more sense. So anytime you have a system, you either can do your servers either on site or you can do them in the cloud, right? On site is the standard usually wherever you go, especially in healthcare, because the cloud environment in healthcare is just a growing system. It's not like there yet, actually. But when you have a data center that you establish everything there, then you need to have what's called like a backup server located in a completely different region, completely different city. Because say, for example, you have a disaster. Let's say you have like a hurricane, you have a tornado, you have something going on, right? Data is wiped. Something happens, you lose connection, anything happens, right? So you need to back up to that server that you have in that different city in a given redundancy. And you do this once every hour. On the hour you do this, because if you lose connections, you need to be able to basically use the most recent data and just use that until you fix the problem. When you have a cloud-based strategy, which is better, of course, and we're moving into this, by the way, over this year and next year, then even the cloud-based strategy will need to have that backup redundancy. And then you're talking about basically like having the primary cloud in a certain city or state in this country, and then the backup one would be in a different city or state, preferably different weather environment, just to to make sure like you're not actually like shooting yourself in the foot by losing both points at the same storm. And I think there's a third question over there. Any regulated authority set standards for this process? The problem is that for the most part, you would think that the government actually would set some standards here. Unfortunately, the government in this country, at least, did not set any standards for how redundant or how much you need to back up. It's just all good practice over here, just kind of like best practice, which is honestly like kind of like shame on us here in this country. This country like that, we're not even covering that from the government perspective. But I think the system in the United States is different from if you compare it to Europe or the Middle East, in the fact that the vast majority of the hospitals in the United States are private owned. And when you're private owned, you better just govern your own stuff, basically. You're just basically going to be questioned about how, not to do any harm to any patient, but then they're going to leave it for you how to decide how to do this. But there's no authority that would actually tell you that you have to do this for sure. But it's a best practice. In Europe, it's different because most of the hospitals are government owned. So you would see this authority is actually the government, as a matter of fact. Like usually it's the Ministry of Health that does this. An example is Saudi Arabia too, because you have the Ministry of Health there too, covering all of these, because the most part, they're like almost like, I think the government hospitals are still the majority in Saudi Arabia. So you still have that governance over there. The question is, how do you make this like life nice for everyone? Making sure like the government and the private follow the same rules. The only place I know actually did this successfully was the UK, England, because the NHS over there did actually have governance all over. And they came across and said, you know what, I don't care if you're like government or private owned, you need to report everything to me. I need to make sure that I control what you're doing. And the government is the one that then sets up the stage for all these hospitals to actually submit and to back up their data. But unfortunately, that's not a standard like in every country. It just depends on where you go.
Okay, thank you. From Samir Khasana, we have a master degree in health informatics at Jordan University of Science and Technology. Will it be beneficial as the BGY one program is hard to be accepted at, or it won't give us the exact experience? What do you think, Doctor?
I think it will help. I mean, again, like, when I look at these kind of things, if two people come and apply to me, one with master's in informatics and one without, I'll take the master's in informatics. I mean, you spend the time. Typically, and even this one even will help if you apply even like for either for jobs, or if you'd like even to pursue future residencies as well after the master's, by the way. I mean, I'm just like saying like all the options are there. This will give you the advantage. But what I also make sure that I make it very clear is that whenever you pursue any degree, don't pursue it just because it's a degree. Pursue it based on the job market that you're having either in your country or wherever you're going. If that master's in healthcare informatics is not a job requirement for a job that you're applying for, you might want to reconsider, because you don't want to just be spending 2 years assuming it will help you while it's not. But I can tell you from my side here, if someone comes to me and show me this certificate over here, I would certainly give them like a plus. Is it a job requirement? It's not. And I was sharing with the leaders earlier today, whenever anyone comes and apply for a job over here, let's take this as a good example, the pharmacy informatics here, because it's not very well established science in the Middle East in general. But if you take that as an example, if someone comes to me and apply, there are only 3 job description provisions that we can take. Number 1, you have a residency in healthcare informatics. Number 2, you are a practitioner in pharmacy, and you have equivalent healthcare experience in informatics, meaning that you worked on projects and what have you. Number 3, you are an inpatient practitioner and you have no experience, but you had worked on projects before with this. Now, for this one here, this last part, if someone comes with a master's in informatics, I'll take that too. But the preference would be for the residency one. That's what I'm trying to say over here. If you have a residency here, it's equal to 6 years of experience, which reflects, of course, in your pay salary, your initial salary to be paid, and all the good stuff that you're going to see in the future. So it's a good thing, but highly recommend that you check the job description for whoever you'll be working for, whether it's a hospital or industry or community or private practice, to see if this is actually going to to be required or not. And plus, you can apply it anywhere else, by the way. You can apply it for research. It doesn't have to be pharmacy only, because usually like health informatics is a wide field. You can go even to genomics and what have you. But you just need to check those job description. If you don't see any of these with Masters of Healthcare Informatics, I would recommend that you try some other route for sure.
Sorry. From Amal, how competitive are such residencies for international students? Here it's quite hard to land on.
That's a good question. So here's the problem when people come from overseas to here. For example, I'll just give you an example of what my program is. Okay, I'm just gonna like just talk about my, because that's probably easier to talk about my stuff. I don't limit people to come to my program from anywhere they want to come. They can come from anywhere they want in the world. Absolutely no problem. I require those people to have to be PharmDs. I don't take anything less than PharmDs over here. The problem that you're going to see is that the any residency that you're going to apply for in this country will require you to be licensed pharmacist within the first 90 days. Okay, so if you can come here and just be a licensed pharmacist within the first 90 days, by all means. But the problem you're going to see is that you need to go through the equivalency exams, and you need to go through like, FPGEC or whatever they call it now. You need to spend hours of training, and usually sometimes this stuff takes time. So, but here's what people used to do when they used to come from overseas to come here. They used to come here, they do the equivalency, they spend some hours in training, they get licensed basically as pharmacists in any state. It doesn't matter where you get licensed, any state is fine, right? And then they apply to these programs. At that point, they will take them. I think there's another route that you can do as well, which is you can apply for only PGY1 international students. There are lots of these programs, but if you go to the ASHP directory online, you'd see a list of these programs. You can just apply. Those are meant for international students. They just apply for a visa for you. They sponsor you, all this stuff. And then you finish like a PGY1 residency. And then what you do after that, you do a PGY2 informatics. Like I said, there are about 20 programs in the United States that teach you PGY2 informatics. That's not allowed too. So the first year will be PGY1 international. And then from there, you apply for the PGY2, which is the informatics residency, right? So either way is fine. But like I said, the only predicament that you're going to see is that you just need to get this license available. If you can get that license worked out, there should be no problem whatsoever in my program or any program I apply for to just come and join us in this case. And I would love to see actually some of you apply, quite frankly, if you can. That'd be great.
Sir, I want to ask you, is pharmacy informatics restricted for PharmDs?
My program is restricted for PharmDs for sure, yes. So for the training, for the residency, yes. For jobs, no, it depends. Again, if you have the experience, some people may take you, but really these days, I don't think so. These days, the minimum required is a PharmD for sure. Like you can't just go, you have to be a doctor of pharmacy for sure, like to be in these, at least the hospital setting. I'm not aware of any program that would require less than that. However, I know that some programs do allow other than PharmDs to apply, but those would be limited. Best thing is to check the ASHP directory, because if you look there, it will just open the program for you. And then you can search there and just like find out exactly the requirements for each program. And some of them do require it, sometimes some of them don't. But keep in mind, the ones who do not require it will be probably more competitive at that point, because you can imagine what lots of people just apply to that.
What about pharmacy and clinical master? Is it good candidate?
For this is good for academic teaching. So if you decide to teach in a college, sure, absolutely no problem. That's a good one for sure, but not in practice. Okay, in practice, we will look at these kind of things. Yeah.
I guess that's a question for me from Muzammil. What about the certificate? Do we get that? As soon as possible, we will send it via email, inshallah. From Samar, how pharmacy informatics will be involved in pharmaceutical industry?
Yeah, and that's a good one also. So basically in industry, they do a lot of what they call market analysis, okay? And in industry, believe it or not, so I worked in industry actually for a couple of years in informatics, so I can tell you exactly what you can do in there. You can certainly work in the research and development, in the R&D. designing those systems we just talked about. You see all these systems we showed over there? All these are designed by pharmacists. So that's your job, basically designing those systems. As a matter of fact, that's actually more entertaining to design a system, upstream that will be released to the public, whether it's like a medical device or IV still company or what have you. Some of them also are included in the market research, meaning that you would also design certain software products that would actually help some other products that the company is using. So we have an example of this. Let's say a company makes a medication that requires what's called REMS. I'm not sure if you guys heard about REMS before. It's the risk evaluation mitigation strategy. Basically, certain medications, I'll give an example, like Accutane. Accutane is used mainly for acne, what have you. Here, you have to, as when given, especially like for women of childbearing age, then you're going to be talking about, risk for pregnancy, right? Risk for high cholesterol and what have you. Someone need to verify all this stuff before a medication is actually dispensed to that patient. So then the informatics pharmacist comes there and helps the organizations build a protocol that actually would go into their electronic health record to ease that process, meaning that I'm trying to dispense or order Accutane for someone. I'm going to be prompted with all these questions over there, right? You are going to be the one who's really designing all the stuff and the requirements and the acceptable limits and what have you. Because when the lab comes back and if it's not within the limits, you will not even authorize it. So you would work a lot in industry like this and also in the insurance companies, the formulary, balance and the authorizations and what have you. And honestly, we can talk for hours about this stuff. I have plethora of projects to share with you if we need to discuss this. And I think it's going to be very useful for the students to just even explore these and see where they are. The good news about the informatics in the pharmaceutical industry is that it will not require you to be a licensed pharmacist. Okay, you're not required to be licensed in there. You can actually work there just directly because there's no direct patient care involved. Unlike when you work in a hospital or community setting industry, it's kind of like lighter, I would say, and it's more geared towards research, analytics, and some, behind the scenes design of these software and hardware products.
Can I contact you, Doctor, to ask more about the residency programs later?
Certainly, yep, absolutely, yeah. I can share with you. Then you can share my contact info with the box over there for sure. Yeah.
Okay. Please, Yahya, if you can share the LinkedIn account here. Okay. From Q&A box, thank you, Dr. Abbasi. How do you see ergonomics playing into the realm of pharmacy informatics?
In pharmacy informatics, they use a different term. I think this was from Sarah, sorry. They use a different term. They use something called human factors. Usually ergonomics are used like for chairs and desks and what have you. But in healthcare informatics or pharmacy informatics, they use the term human factors. So what this means is that you design a system, right? And this goes mainly for the industry. And then the informatics pharmacist would come and make sure that I am as a user, I am as a pharmacist, I am as a clinician, as a doc, as a nurse. When I use the system, it actually works very well with my workflow. So for example, if I'm verifying an IV, an example over here. Let's say I'm designing an IV workflow system, okay? And the IV workflow system has a monitor, touch screen monitor, right? And then you have a compounding system over there. What's easier? Is it easier for me to have the monitor outside the hood or inside the hood, right? So think about this way. I am as a practitioner. I'm going to be basically doing this compound, I mean, gowned and gloved and all this stuff, doing the compound there. Is it easier for me to keep taking my finger and just go to the screen, just press the button, come back here to what I'm doing and keep going back and forth like this? Or is it easier for me to have it just in front of me? So that's where your testing is going to go with the industry, give them that feedback and tell them, these human factors would suggest that you put the monitor inside the hood, actually, not outside the hood, because that's what the workflow dictates for you. That's what they refer to with human factors in this case. And you can build on these many examples, of course. Now, this specific example is interesting because the idea behind the sterile field inside the hood is that basically, if you look at like the USP 797 standards, there's some ISO requirements. You know, the ISO, the International Standards Organizations, International Standard Organization. So what you do in this case, they'll have requirements for the quality of air inside the hood. I think we call it ISO 5, meaning that you have to have very small number of particles inside that area. Outside that hood where you compound, it's called ISO 7. They'll give you more allowance, but technically it's more dirty, quote unquote, than the inside of the hood, right? So here's the problem. If you put that monitor outside and your finger is going back and forth, so your finger is going between an ISO 7 and ISO 5 environment. You're technically contaminating your stuff without you knowing. No one really like thanked anyone about this, but that's also another problem that informatics firms can point out. And that is that you want to have a safer practice here. Why do I need to do this? If you want to expand more into this, you know what, why don't I just use like maybe like a holo program here and just like have that screen just be displayed by an augmented reality for me and just interact with it that way. I'm not sure if you've seen this, but they actually exist, these products today. You can actually establish a keyboard in the air and you can just like just type on it. Now, you know, someone who's going to be looking at you from the outside, you're going to say like crazy person just typing in the air, but actually you're seeing a keyboard in front of you just typing. But those are the ergonomics, or what we refer to as human factors here. Okay.
Thank you. From Ahmed, does the certification course is available for distance learning? I guess regarding the courses that you shared.
It does exist. Again, your problem would be to work for an organization that has these, whether it's like Epic or Cerner, because they'll give you an option of do it either in person. You go to a city called Verona in Wisconsin. That's where Epic is located, or you go to Cerner headquarters in Kansas City. That's where you go in person, or you can do it remote. Most organizations, especially during COVID, did it like remote, and they still offer that option as well.
From Yara, do these devices which alert pharmacists to dispense protamine work without a physician order?
They do. I guess the question is like, how do you want to use them? Because those are the Echo Dots, the Amazon devices. I mean, those are like great devices. Just teach them what you want, right? So basically, you can always you know, use it for anything you want, like music, or ask it for drug info, what have you. But the value here is that how are you gonna know about protamine if there's no order? Like, how do you know? How would the device know, right? So you need to have a feed that comes somewhere, right? And in this case would be your electronic health record to that device to let it know that I have a protamine order, right? That is the feed that you need to have, ping it, or any other means. If you can think about any other mean, absolutely. But there has to be something to tell the device when to actually start this announcement that there's a protamine order. Otherwise, the device is just a dummy device.
From Sarah, how does BI influence health outcome?
Because when you look at the reports that you're looking at, that's where you're actually what we call like health, population health. That's another term that I'm sure like if it came to any discussion here applies, because you're going to be looking at your at the behavior of your community. Okay, dispensing behavior. I'll give an example over here. Let's say that you have a population that you're concerned about. Let's say a smoking population, people who smoke. Okay, and you want to see like, you know, how good or bad is a given therapy for smoking cessation. Okay, then, you know, maybe like you have Chantix, one of the medications that's used for this, or maybe like the patches for smoking cessation, whatever you want to use. Okay, then you assume that this is a very efficient way to prevent smoking, but you cannot record it, right? I mean, I don't know. Like people come to me, they're like, hey, you know, I'm smoking, you know, all this stuff. You know, I smoked Argila yesterday, whatever, I'm gonna smoke. Like, okay, good, great. Then you're gonna stop smoking. Like, how are you gonna document this stuff? How are you gonna know that this person actually stopped smoking, other than just like watching over their shoulders? Well, what you can do, you can actually monitor how often a given medication is actually dispensed for someone, right? And you can actually monitor that versus like maybe some lab levels that you can acquire for these patients. You can see if a given community with very high Chantix prescriptions being dispensed, you compare that community, maybe like, you know, cancer screening results for lung cancer, right? Or other biomarkers with a different community that are not using this. And then you can measure based on that. You can measure that, because we are having so much Chantix dispensing over here and adherence, hopefully, right? Then we're having less biomarker outcomes that we're seeing. That's just one example. Or if you even like simplify it for something like cholesterol monitoring or what have you, you can say, okay, well, how am I going to monitor actually my patients who are utilizing maybe atorvastatin or rosuvastatin versus someone who's not? Basically, you need to link all these medications and their doses with the labs that you're measuring, because now you can say, okay, well, here's the outcome I'm having based on a 10 milligram of rosuvastatin on the outcome of the population I'm having. So the pharmacy informatics would come here and say, let me actually measure this for you. Let me measure it for you. Let me run these reports for you. And you as an informatics pharmacist is the one who's going to be determining those indicators and what would make sense and what doesn't make sense, to come to a provider or to a hospital leader or director or CEO and tell them, you know what, I think you need to put Chantix on formulary because we're seeing a very positive outcome over here out of this. And that is how you're going to impact the outcome, because then your Chantix will become covered, let's say, by the government. Okay. Have patients pay nothing for it. Why do I need to have someone pay for smoking cessation if it works, right? It's actually cheaper for me just have them just take it for free if that's the case, if it works, right? So that's the kind of thing how you get involved in the decision-making process. But you need data. Data is the main source of power here for informatics pharmacists, that you need to know how to understand, first of all, and then how to apply and how to influence others with it. That is your job over here as an informatics pharmacist, for sure.
Does a Houston Methodist offer EHR certificates?
Yeah, absolutely. And I mean, so here's the thing, EHR, this is offered by the EHR vendors, okay? So I don't certify you, Epic would certify you, but I pay for Epic to certify you. That's how it is. I give you the residency graduation for sure from here, but the EHR certificate comes from the vendor of that EHR themselves, whether it's Epic or Cerner, other systems called Meditech. And those certificates are very powerful, folks. I mean, the idea is that if you get one of these, any organization would just dream of hiring you. That's my point over here. Because number one, it shows that you're trained. Number two, you're saving them the expense for just paying for that certification for you later on.
Great. Will pharmacy informatics replace clinical pharmacy?
No, two different fields. Absolutely different fields, not related.
Okay, this question from me, actually, as undergraduate student, what skill should I have to be or to ease the entry to the pharmacy informatics field?
I think engaging a lot with, well, number one, you need to just follow like basically like the current trends in the market, right? A good resource would be like things like LinkedIn, sometimes following what either ASHP publishes, what we call like HIMSS, HIMSS organization, which is the Health Informatics and Medication Society, publishes. And then you are up to date, basically. Then you know where the trend is. But I think from what I can tell you, the trend right now are a couple of things. Basically, if you're looking, and again, depends on where you want to apply this. If you want to apply that, for example, within a country or within a region, versus if you want to be universal. If you wanted to apply it universally, overall, the best thing would be to look at ambulatory services, meaning that those mobile technologies we're talking about, because that can apply everywhere. If you can actually start familiarizing yourself with basically how these systems interact with each other, how to maybe how the app space works. How do you make an app actually on iPhone? Like there's just something as simple as that. I'll give you an example, Dean. So basically, someone applied to my residency a while back, and my residency
is Python, like programming skills?
No, but that's what I'm saying. Like I don't think you need programming skills at all. But I think what you need is to have an idea where to start with these. Programming is good for sure because it gives you some tools that you can use. But I was just giving you an example of one of the students who applied for the residency here a couple of years ago. Well, we couldn't take him because it was very competitive, but he was a third-year student and he actually created an app that actually enhances patient adherence. So basically what it does, it actually have the patient document their medications, actually what they're taking day or night, right? And actually it just reminds them basically on these medications, and it sends the outcome to the pharmacist. So you would know if they actually took it or did not take it. Now, regardless of whether like this is a marketable like solution or not, because I have so many questions about this, in terms of compliance or adherence. But that was one thing that I liked about him, because it means someone is thinking outside the box. What would also help is that if in your free time you can find some remote part-time opportunities with either maybe like healthcare data companies, some folks who actually deal with data analytics, and just start looking at their data, even if it's something that has to be with volunteering or internships. I think those are just great opportunities. Just start looking at the data, analyzing it, and see if you can actually start providing services based on these. All this stuff will go on your resume, that you actually worked on something like this. And then when you apply for the next phase, any employer will look that actually you are genuinely interested in this. That's what makes a different people. Basically, like the difference between one student and the other is how much time you invested into a specific topic versus the other one. Because if everyone's just applying to a job or residency, saying that, here are the rotations I've done throughout my career, here's like the courses I've taken, here like all my A's or B's. And then one student just adds that I worked on this project and specifically for this. Well, that kind of like weighs against everything else, because basically you showed me that you are genuinely interested in there. And that's what's important for me. I care about grades for sure. I care for sure about grades. And I care about being someone who's dedicated, but I also care about the project work. I care about the quality that people are doing, and I care about dedication. And you have to prove this by basically trying either to volunteer or to work for certain company, even as part-time. Part-time is fine, by the way, but just shows me like how genuine you are interested in this field.
So, also as an undergraduate, because undergraduate, how I can know if I'm candidate regarding the resume that I have, or what should I know?
You can always check like with someone who is expert in the field. I mean, I'll be very happy if you'd like to share anything with me. I can show it to you like how things. But typically, I mean, make sure that here, and we can do another session by the way on resume writing. That's a different thing as well, because I also help to coach lots of employees as a mentor for how to be efficient when you write your resume and how to grab attention from people. Because really you want to make sure that you market yourself very well and you focus on the keywords that you're putting on that resume or CV, so it stands out basically. But you need to focus at this level as a student. There probably isn't like too much experience to put into the resume because you haven't like worked in any organization perhaps until yet. What would help is if you actually start putting down again, like those smaller projects that you either worked on or are actually working on right now, right? Or like looking into, and some skills that you own. For example, if you have like data analysis, data analytics, anything that you actually think is related, this will add to your, for sure, to your benefit on your resume. And that can be tricky for students. That's why I was saying like residency is probably the best thing, but also show some sort of genuine interest in your resume, either through a project that you are worked on, or through some keywords in your skill set that actually relates to this. And I'll give a quick teaser over here. You probably guys hear about ChatGPT, the ChatGPT that went over the market. Something ridiculous like this. I mean, I would just start using it, right? So, it might be something maybe just to look into. Just maybe understand how this works out. You can actually put in the resume, research ChatGPT and is working on a paper publication. You can put that on your LinkedIn profile and reference it. That still shows that you're actually interested into this field, even though it's something that may not be peer reviewed or something that may not be published, but it shows me as a student that you are actually interested, and that's what I care about here.
Nice, very nice. Thank you, Dr. Abbasi. We appreciate your time and effort and the valuable information that you shared with us. Actually, your insights have broadened our understanding of the intersection between pharmacy and technology. And thank you for all audience who were with us. We hope you found it informative for the future of pharmacy informatics. We look forward do you to continue involve in similar events in the future that we shared in our LinkedIn and IVPN listserv, email, and that's it. Thank you. And if anyone have any question, please share it before we end. Special thanks from Dr. Bushra Hijazi. Thank you, Dr. Bushra, for being with us. Thank you all. I guess, thank you all. Actually, we are very happy because you join us, Dr. Abbasi, and thank you for all audience again, and goodbye.
Yeah, my pleasure. Have a good one, everyone.